First thing I want to do is say many, many thanks to all of you for all the fantastic work you've been accomplishing over the past 2 years. I know it's been a grind, and the Department of Medicine has held the fort without saying much, and the work in very difficult circumstances. So thank you so much for that. And do want to thank the leadership as well. Not easy leadership in our days, and many issues. So just want to thank Norman and her team and the leadership team in the Department of Medicine for the fantastic work that they've been doing. So just in terms of disclosure, and I'm an employee of AHS. I'm proud to be one. I have a small MHSP contract for my clinical work, and I do have a couple of grants as part of a group of principal investigators, but it's really as a collaborator and not as a the primary investigator. I do have to give some credits to my team that's helped me put some of this presentation together. So I want to make sure after that we have a tremendous quality health improvement team in our in AHS, and I think you know that, but I want to offer them my thanks as well. You know, one of the things that, you know, I wanted to do is share maybe a bit of a personal thought. This is my family. And, you know, the past 2 years, I've really kind of, you know, as much as you, I've reflected on what's important for me. And, you know, my family is tremendously important. This is what I live for every day. And I think the past 2 years has sort of, you know, given us an opportunity to all of us and reflect on what's important in our life. You know, another personal story is that for me, public speaking was actually been very difficult. When I was a teenager, I was 19. I was mostly speaking French, very little English. And so when I started medical school, I had to learn English plus all the medicine, and therefore I was a little bit shy, and public speaking was actually very difficult for me. But I've worked really hard at it. And, you know, I'm still striving to be like Barack Obama, but I think I'm a little better than Daryl Sutter. So just want to highlight that. So anyhow, or at least a little more engaging, and hopefully you'll find so as well. So today, you know, I'm using the topic of Mission Possible for peak performance in healthcare. And it's really to look at, you know, how we can go through this very tough period using a transformational lens. And it's really about not only transforming the health system, but also transforming ourselves. And, you know, I'm using the analogy of 14 peaks. Nothing is impossible. Actually, the Nepalese mountaineer Nirmal Purja used Mission Possible. So him and his team attempted to climb 14 mountains over 8,000 meters. 8,000 meters, as you know, is the death zone, and within a record time of 7 months. And he did this to bring attention to the unsung and underappreciated heroes of mountaineering, the Nepalese Sherpas. The previous record was over 7 years. 7 years, somebody did the 14 peaks. He did it in 6 months and 6 days. When he summited the first peak, Annapurna 1, on the 25th of April of 2019, Purja had only locked down 15% of financing he needed. And most of his money came from remortgaging his house in the UK. However, as the climbing went on, he managed to, you know, raise some additional dollars with GoFundMe campaign, corporate sponsorship, and managed to achieve his goals. So it's really a story about overcoming adversity, leadership, integrity, and willingness to learn. And I think, you know, hopefully this is the kind of approach we can take as we have to meet significant challenges in healthcare. So I'm using this as a metaphor to overcome the challenges of summiting the world's most dangerous, highest mountain peaks, to overcoming the challenges facing our healthcare system today. Our metaphor is that meeting the challenges of healthcare system offers us what is mission possible, but we can't do that alone. We need a team around us. We need to work together so that actually we can achieve the challenge. We can overcome the challenges that we face today. So if you want to see the actual documentary, it's on Netflix. It's a couple hours, and it's really heartwarming. To ground folks, I do have a patient story. In AHS, actually, we provide opportunities for patients to tell their stories their own way. They create their own narrative. They film themselves. They choose their music. They choose their slides. We provide them with a photographer and a video maker. So it's their story. I'm going to present today Christine's story. It's not it's a story that could be adapted. It's a pediatric story and didn't choose it purposefully because of that. But it's actually the reason I've chosen this, because it highlights the current challenges in navigating the health system today. And could be applied actually to whether it's pediatric seniors or any other environment. The story is about 3 minutes, and hopefully we'll get the technology to work so that you can certainly hear it properly.
On July 17th, 2014, at 7:32 p.m., we were blessed with a beautiful baby girl. We named her Ellie. All seemed routine until 12 hours later, when both Ellie and I suddenly became critically ill. We were airlifted to Calgary and spent the next 18 days between the Foothills Hospital and the Medicine Hat Regional Hospital. Eventually, we were discharged with a clean bill of health and returned home to begin our life as a family of 5. Then one February day in 2017, we noticed concerning behaviors and physical symptoms in Ellie, which prompted us to seek care from our pediatrician, who quickly referred us to the Alberta Children's Hospital. Walking through the hospital doors again for the first time after the traumatizing events of her birth made my heart race and my hands tremble. Ellie suffered from what was thought to be a rare disorder and began being followed by a number of specialists. Over the next 3.5 years, traveling for care and diagnostic testing became a way of life. Our family was forced to revolve around appointments and trips to Calgary. Trying to maintain a sense of normalcy for our 2 older children, juggling mine and my husband's careers, all while adjusting to our new normal for Ellie's care, was overwhelming. Almost daily, I felt enormous levels of anxiety, guilt, and stress. Ellie's care became a full-time job. In addition to managing her at-home care, I had to coordinate specialist consults or diagnostic testing to avoid multiple road trips every month. Still, Ellie and I would often travel 6 hours in one day, sometimes in dangerous conditions, for a short 30-minute appointment. Ellie suffers from severe medical trauma, and I would often leave those appointments with no new answers or direction, thinking, there has to be a better way. There is no reason Ellie should have to go through all of this. And then came COVID-19. I had no idea how we were going to manage all of these appointments in a pandemic, and was shocked when I found out that for the first time, we would have a phone consultation with our new endocrinologist. I remember sitting down at my kitchen table, phone in hand, while Ellie and the boys quietly watched a movie in the other room. There was no crying, screaming, or consoling, almost no anxiety at all. We spoke for over an hour, and when the appointment was through, we had a plan, and for the first time in a long time, I felt like I could breathe. As I told my husband about the call later that day, I began to cry. Not tears of frustration, but tears of relief. After 4 long years, I had a sense of control over how Ellie was receiving care. As parents of a medically complex child, we fully understand what warrants a face-to-face appointment. It has been amazing to be able to now schedule a follow-up call during my lunch break at work. Pre-COVID, the option for virtual appointments was not considered, even when we requested. It is clear now that the system had the capability, but not the will. Patients deserve a seat at the table in the design and delivery of healthcare, and now we know that can happen at their own kitchen table.
So for me, it's sometimes difficult to feel close to patient care. We're in my leadership role. So I meet with patients regularly and try to use some of these stories to help, in my clinical work to keep myself grounded. And, it's a reminder of maybe what's important for people, patients and people we actually work for. What's important for them we may not see it as important for us. So what are our challenges? And I've divided that in 5 what I call the 5 peaks. The first one is system integration. And, we've done some improvements there. There's been some improvements both during the pandemic. There's improvement by implementing clinical information systems like Connect Care to try to bridge the gap in terms of system integration. But we remain too, and I think all of us will agree that our system is too siloed. People are working hard, not always working together. And, I think there's still a fair bit of self-interest out there and a lack of accountability for the system. People are accountable to their own areas, but not always to the whole system. So that's one of our significant challenge. The second challenge is really access. We have a huge problem. We've put some priority in terms of surgical backlog. We have an issue in terms of rural communities. The health inequity is huge. This has been a light was shined on health inequities during the pandemic. We all know that folks, social environments, income, all affect their ability to do well with COVID or other illnesses. Therefore, huge issues from our perspective. So access remains, despite a lot of improvement, access remains a big problem. The third peak, or the third group of challenges, is really the social determinants of health. And I think this group is well aware of this. Everybody's aware, right? The social isolations that our seniors feel. It directly related to hospital admissions. The 560 group, the group of patients that is very highly complex, that has mental illness, addiction, that doesn't have a home. Their only resource is really the emergency department, leads to all sorts of issues in terms of their own healthcare, but also from a health system perspective. And finally, chronic disease. I think the biggest chronic disease we're going to face moving forward is actually mental health. Mental health, what's happening now and what I'm seeing is I'm seeing a real societal anger and anxiety. We have seen a real jump in that through the past 2 years. And I think it's going to be a huge issue over the next 3 to 5 years in terms of evolution there, or a post-pandemic, or an evolution of our pandemic as we move forward. So that's the third group. The fourth group is really about our workforce. The impact has been tremendous. Our workforce has created significant fatigue. Our physicians and staff are reevaluating their role in life, their role in healthcare. We've been dependent on the goodwill of many over the years, but folks have simply hit the wall. And we're seeing major impacts in terms of our termination rate, our sick rate, our retention rate. And so it's not just Alberta. It is a national issue. We need a national conversation about our workforce. We need to look at this problem very differently. We'll talk about that in the next few minutes. It's probably our biggest challenge at the moment, and our biggest challenge over the next 2 years, 2 to 5 years. Spreading. I'll talk a little bit about unwarranted clinical variation and system variation, but we need to be better. One of our big challenges is spreading local improvement and successes, spread and scale across the province. I think one of the biggest hurdle that we have is really unwarranted clinical variation and business variation to that extent. And to be a bit provocative, while some variation is acceptable, and required, as providers, we really practice unwarranted variation to justify our autonomy, and that at the expense of evidence-based care, and at the expense of a sustainable system in the long term, and I think at the expense sometimes of quality and safety. So this is something actually the profession can own. Us as medical workers, healthcare workers, physicians, other health professions, we can own this. And we can make a huge difference in terms of our ability to sustain the system on the long term. Our last challenge here, our last peak, is really about the system funding. At over 40% of the provincial budget being dedicated to healthcare, it's become a headache for a politician, a societal leaders. And it's really going to be a challenge to maintain this level of funding or increasing funding with increasing demands due to higher incidence of chronic disease, older population, new rapidly evolving technologies that are expensive. So there's huge pressure on the system to become more efficient and more sustainable. Interestingly, we were the highest per capita of the 10 provinces in Canada, 5 years ago. We're now 4th. So we've been able to bend the cost curve, through a lot of work and a lot of effort. But still, a rate of growth this year is expected to be 2.6%. If you compare that BC and other provinces, you're looking probably at around 4%. Some are better, like Quebec at 4.4%. So the issue will be, we're going to need some increase. We're going to need some rate increases in terms of sustaining the health system. But the question is, how do we maintain the funding, and how do we maintain services based on the funding that we have? And how do we decide, what core services, we need to fund? So, how do we get out of these challenges, and how do we look at the future is really what the next part of the presentation is about. I think one of the things we need to ground ourselves is the quadruple aim. There's really good evidence that if you actually use the quadruple aim as your framework or your backdrop in terms of how you prioritize healthcare initiatives or health system improvements, you are going to improve health outcomes. And by improving health outcomes, you're going to reduce variation. And by reducing variation, you're actually going to be able to sustain the system. So to me, that is really continued to be the backdrop of what we need to do, and cannot lose, or we just got to keep our eye on the ball on the quadruple aim. I think that's critical. The second piece is we should start asking ourselves some really important questions. How do we define success? What is the organizational structure we want to foster? What are the behaviors that follow that organizational structure that we're going to not just sponsor but also ensure that they're adhered to by our medical staff and our healthcare workers? We need to ask some key questions. We need to be leaders in modeling the transformation. We need to ask ourselves, are the services good quality, and for whom? Is the access timely and fair? Is the system efficient? Does it deliver good value for money? What services are appropriate? What services are overused, underused? We need to ensure that we have performance metrics so we can actually measure ourselves against some kind of benchmark. And all of this need to make sense to folks. We need to have a narrative that actually we can communicate effectively, and that people feel not just empowered, but they feel they're part of something that is coherent, and that actually gets us to a better healthcare system. One of the ways that I found really useful is, and I found as a kind of a framework that really resonated with me is the work by Vijay Govindaranjan, which presented actually at our I4 conference, and it's called the 3-box solution to as a strategy to lead innovation. And it's really focused on, it's really focused on working through 3 areas. Work, first of all, is managing the present. You can't fix the future if you're not going to be able to manage the present. Second is, we've got to be able to selectively forget the past. You're going to have to drop your old practices and things that don't work anymore. And thirdly, you've got to create the future. So I'm going to give you some examples. I'm going to use this to try to give you some examples in terms of each of those boxes. Box 1, which is about managing the present, is really focusing on core business, addressing the workforce issues, reducing variation, improving patient safety, enhancing efficiency while imagining the future. As I mentioned, you got to work through box 1 before we can actually go through to box 2 and box 3. So what do we do, for example, about our workforce problem? We have developed an integrated workforce plan. The integrated workforce action plan is an overarching initiative which enables coordination, monitors, reports, evaluate AHS short-term and long-term workforce integrated planning and supply initiatives to build workforce capacity. The action plan, it works through the goals, focusing on short, intermediate, and long-term action. It is really focused on rural workforce, nursing, physicians, allied health, and frontline leaders. And and so that's the plan that we've developed. We're still in the process of actually discussing this with our board and with Alberta Health Services. But this is it's focused on not just recruitment, but really on a retention strategy. We all recognize that we need to achieve a certain level of compensation, but it's not just about compensation. It's about, you know, ensuring that we have folks doing the right jobs, working at their full scope of practice, and feeling like they're valued. The second point about managing the present is really about, you know, addressing the issue of clinical variation. I've already spoken about this, and I think Stephen Lewis is right. Stephen Lewis is an adjunct professor and a health policy researcher that's well known as a consultant, both comes from Saskatchewan and in Alberta and BC, and he calls variation as unjustifiable, as the enemy of excellence. And further, if you don't care about variation, you really don't care about system performance. This is something that I think we need to address as an organization, but as a leadership. It leads, you know, unnecessary variation gives poorer patient outcomes, more investigation, more costs, and an unsustainable system. Give you an example. You know, this is the urine culture per 100 ED visits in a number of sites. So the each line represents a site in the province, and this shows you a fivefold variation. There's some variations probably acceptable, but probably not fivefold. So this is the kind of problem that we need to address. And, you know, we got to use the tools that we have. So this is actually so there's been an initiative that has been actually implemented provincially, looking at how we can improve our urine, our utilization of urine culture in the province, and we focused on emergency departments. So this is a Calgary zone, Calgary zone initiative, you know, by implementing a key. So by using, for example, Connect Care, which you have here in Edmonton, which actually shown similar improvements. And as an enabler to make sure that we can actually give audit and feedback back to our practitioners and to healthcare teams to ensure we have point of care decision support, make sure we have a change management process for changing the behaviors and a monitoring system so that we can sustain the improvements. It can be done. You can see the improvements here. Let me give you an example which is a little bit closer to home. So this is actually at the UAH. This is at the University of Alberta Hospital, and with the implementation of Connect Care and using things like stops and reminders as part of the implementation of Connect Care, we've been able to reduce the utilization of a number of investigations. And so, you know, I think actually if we have the tools and to make this happen, I think a lot of what we need to do in terms of improving unwanted variation is about willpower. And it's about our will to do it. It's about our governance, and it's about ensuring that we have the mechanism in place to ensure that both, you know, the change management and the monitoring is in place, and the accountability is actually in place as well. The second box is really about forgetting the past. It's really about, you know, getting out of the tunnel vision and thinking that what we've done for many years is still good. And we've got to abandon certain activities that are not relevant for the future. And we've got to unlearn things that are not really helpful. So some of the examples I'm giving you here, you know, we used to think that in-person visits every time was the standard. Well, it's not. We've implemented with the pandemic, 25% now of outpatient visits are done virtually. Virtual health is not for everyone and for every circumstance, and we need to have an organized approach to virtual health, but it's certainly something that we don't need to do inpatient face-to-face visits on every occasion. Clinician knows best versus, shared decision-making with patients and families. I'll talk about this in a few minutes. I think we've got to get to a place where it's a lot more about co-design and shared decision-making rather than the provider knows best. Bundling, automating order sets for efficiency versus selectively ordering only what is necessary, something we've learned. This is a Connect Care uncoupling of PT and PTT, and shows the improvements of us by doing that intervention. So box 3, which is really about creating the future together, is really about what are the opportunities, that we can undertake in the environment that we're in. I've chosen 4. There's probably others to consider, but I think we and again, you got to use kind of the best evidence to try to address a small number of priorities. Too many priorities is not a priority, so you really got to focus. The first one is patient-centered care, patient co-design. I've used some example. The example I've used here is repurposing HealthLink. I'll discuss that in a minute. Digitalization of healthcare, I think, is really important. And finally, using data and analytics as an enabler and as a tool for us to make evidence-based decision is really critical. The first example is really about about shared decision making, and I think one of the best examples that I've seen is really the Scottish experience around realistic medicine. Realistic medicine is about enhancing patient-provider communication, reducing unwarranted clinical variation, reduce waste, improve patient outcomes, and really by making healthcare interventions with patients taking into consideration their quality, their goals, their quality, and what they want out of life. The program is really grounded by listening and understanding their problems, their preferences. It's heavily shifted towards shared decision making between healthcare professionals, their patients. It ensure that patients have all the understandable information they need to make informed choices, including the evidence. It moves away from doctors knows best culture to ensure a more equal partnership, supports healthcare professionals to be innovative, pursue continuous quality improvement, and manage risk better, reduces the harm and waste caused by both over-provision and under-provision of healthcare, and identify and reduce unwarranted variation in clinical practice. They've been very successful in branding this in Scotland. You can go on their website. And what we've done is we've used their model to develop our own brand called Right Care Alberta, which is refocused on 3 things: a number of clinical appropriateness projects. The second is shared decision-making with patients. And the third one is really moving really bring to light the issue of unwarranted clinical variation. One of the things that we're moving to do is actually creating an atlas of variation. So this is not new. It's in Australia. You can go to the website. Australia publicly publishes an atlas of variation. It's geographically based, and it's developed around 6 different conditions. It's also in the UK. And basically they publish, it's very public. They publish by different regions in Australia, the incidence of, for example, of C-sections, and the variation in C-sections. So it's really quite powerful because it is a way to not only sensitize the population, but also sensitize the providers and bring to, the evidence in front of providers in terms of the clinical variation that they have. This is the model that Brent James used as part of Intermountain Health in terms of quality improvement. It is a model that is used elsewhere, but we are actually on the journey to develop our provincial atlas of variation. We're going to have our first iteration in 2023. That's our plan. And really, the whole point is to bring the light under the variation that exists clinically, and to share this with our providers and share this with the patients, so that it actually leads to to initiatives that that improves care by using more evidence-based medicine. The second example is really around HealthLink. So when we started with HealthLink in the pre-pandemic, we essentially a very traditional service with a nurse, using a protocol to provide health advice. This really is kind of the model. I have 2 minutes. So this is really kind of the model that we had. We were inbounding. So our inbound calls were 700,000. We're now at 3.7 million inbound calls in a matter of 2 years. We went from 200 FTE to 800 FTE. Not only our inbound calls have increased by 400%. Our outbound calls were several 10,000s. They're now 1 million outbound calls. So HealthLink has transformed itself. We're no longer just about health advice. We're about helping every Albertan that calls us in managing their healthcare. We've got physicians triaging HealthLink patients. So those, when you call HealthLink, you may be told, well, you got to see a physician within 4 hours. All of those patients are given an opportunity to meet with a physician virtually. And that physician actually has helped us. 50% of those, so we got about 4,500 patients now that have access to a physician, what we call an MD, HealthLink Triage MD. The HealthLink Triage MD has managed to provide advice to those patients where over 50% of the time, they don't have to see a provider. Less than 10% have to come to the ED. So this is the kind of service that we provide. We've got a number of other interventions, mental health, very active in the management of mental health now in terms of a mental health line. We're starting an indigenous health line at the end of the month. We're now using text messaging. We're using other technologies to provide advice to Albertans. So if you have a COVID test, you're going to get your text. We'll come back to you that tells you this is what you need to do. And then you can ask questions, and then there's an automated service that gives you some further advice. So HealthLink has transformed itself. We need to continue to do that. We actually have now combined HealthLink with virtual health. These are portfolios we've combined together, but it's actually a cornerstone from my perspective in terms of helping Albertans in owning their health and managing their health. I'm going to talk a little bit about the digitalization of healthcare. I understand that I'm close to time. And I think that's a game changer. That's a game changer in terms of the various services now that you're going to be able to. This comes from Channel 3, which is a consulting firm in the UK that's worked with NHS quite a bit. But it's going to be a game changer in terms of not just the services you can access as a member of the public in terms of digitalization, but personalization in terms of data gathering, in terms of the technology. We're on a journey with our virtual health program. Our virtual health program we have a strategy, we have a shared database framework, we have an evaluation framework. It's really based on modernizing, harmonizing, coordinating, and tracking our improvements. So I see I see this being a game changer. Similarly with the role of artificial intelligence. I think there's a big focus here at the University of Alberta. We also collaborate with Mohammed Mandami at St. Mike's. They've recently, interestingly, undertook a partnership with Signal One. It's called Signal One, a partnership with the industry. And they're developing their own early warning system. We've got our own, by the way. We've got our own early warning system in Epic. I think this is the kind of thing we need to develop in order to be able to predict who is going to get sicker and give us more information about how to manage the health system and how to manage your patient populations. I'll quickly go over the personal devices, home screen kits. I think you're familiar with that, but again, another part of how we can actually use technology to advantage in terms of managing patients closer to home in a more responsive fashion, more patient-centered. Finally, so our journey towards peak performance, I think, passes first of all by creating the future. Imagine what's possible. It's difficult in these times, but I think that's what we got to thrive ourselves and we got to motivate ourselves towards. deliberately de-implement. We got to leave behind what's not it's not evidence-based and what's wasteful, and effectively manage here where we are here and now. And just remember, to go back to our Sherpa and his story, the previous record was 7 years. He did it in 6 months and 6 days with his team. He did Everest and 2 other peaks in 2 days and 30 minutes. And when he submitted the first peak, he only had 15% of funding. So mission possible. Thank you.